you. I would like to ask the last presenter, Dr. Okata.
I'd like to thank our company and inviting me to speak today. I'm very glad to have this opportunity to discuss with specialists in the world. I'm a pediatric surgeon at the COVID Children's Hospital. COVID here, and our city is very beautiful. So when you want to come over, please contact me. I'll guide for you. Today, I'd like to talk about the experience of using adult biodegradable stent for a young child. This is the first case in Japan for a young child where adult stent has been used. We present the case of using an adult biodegradable stent as an alternative treatment of refractory benign s.r.o fracture after surgical repair of the long-term fracture. Our patient is reborn, she's very cute and cheerful, and she's good at playing the piano. But since her birth, she has only been able to drink liquid or eat fast food. She was diagnosed with long-gap EA after birth and gastroesophageal esophageal fistula closure and esophagostomy were performed. Subsequently, she had 3 sessions of multi-stage extrathoracic esophageal elongation procedure, known as Kinross procedure. At 1 year, 6 months old, esophagostomy was performed via tracheotomy. After the operation, anesthetic leakage and frequent vomiting caused by severe gastroesophageal tract. Let's see underwent recent complication. Upper gastrointestine revealed esophageal anesthetic stricture and fast endoscopic bowel dilation was performed. She developed refractory anastomotic stricture resistance to multiple attempts, such as esophageal dilation combined with steroid injection, intravenous and oral administration of steroids. She also had magnetic compression revision for anastomotic stricture at 3 years old. So this procedure could not relieve anastomotic stricture. The patient had been repeatedly receiving progressive esophageal bowel dilation every 2 weeks to 2 months. At 5 years of age, she was referred to a hospital for Paediatric. This slide shows our first stenting under the approval of ethical committee of our institution and informed consent obtained from our patient's parents. Esophageal stenting with 18 mm diameter and 40 mm length 3D stent was performed, and the general anesthesia after bowel dilation of AS here. 3D stent was inserted. This slide, 3 months later, this fracture occurred again, and endoscopy revealed the second stricture, distal end of the stent. And endoscopic bowel dilation to the second stricture improved this fracture, but the original anastomotic stricture recurred 5 months after the stent. As the next intervention, she and her parents desired to insert the stent again. Therefore, a second stenting with the same type of 18 mm but of 17 mm range stent was performed. In order to dilate both an anastomotic stricture and the second stricture. Postoperative chest abdominal pain and vomit were more severe than the first trial, and she required strict pain management for the first few days. I'm sorry. After the second BD stenting, the third stricture at the distal end of the stent was formed. All of this. Thank you. Also, she did not require S4G duration and could take food orally for 7 months. This quadrilateral endoscopy revealed the recurrence of the original AS, while the second and third structure spontaneously improved. 2 sessions of BD stenting revealed that BD stenting could increase in the interval between dilation and longer discharge-free period, which shows that another stricture at the distal ends of each stent may have been induced by continuous mechanical damage of the stent mediating force and associated with mismatch in luminal size between the esophagus and the stent. We recommended her and her parents to perform reanastomosis of the esophagus, combined with such as coalescence unification or interposition, but they refused our recommendation. Therefore, we continued to try BD stenting. The third BD stenting was performed 18 months after the first stenting. We used a slightly smaller and shorter one because we hypothesized that this may prevent another stricture formation at the distal end of the stent and may relieve post-stenting symptoms. Actually, post-stenting symptoms were not severe, but she needed an analgesic agent for a few days. Surprisingly, another stricture formation was observed not at the distal end of the stent, but proximal end of the stent at 23 months. The fourth BD stenting was performed at 27 months. We used one smaller in both diameter and oral end flare to avoid stricture formation at the proximal end of the stent. However, anastomotic stricture again recurred after 9 months. In this time, post-stenting symptoms were slight, and another stricture formation was not observed at either end of the stent. Finally, we performed resection of anastomotic stricture with right strapotomy. Adhesion around the esophagus was mild to moderate, but adhesion around the anastomotic stricture and very severe, and the esophagus came backward. We rejected the anastomotic stricture and end-to-end anastomosis was performed without translucent procedure. After the operation, anastomotic minor leakage occurred, but healed conservatively. This slide shows the pathology of the resected specimen. The anastomotic stricture region was composed of thickened scalp, without any component of normal esophageal wall, but is only thin mucosal layer. Both the upper and lower end of specimens have almost normal mucosal and submucosal layer, but irregular arrangement of muscle layers were observed. In our case, 4 sessions BD stents only increase the interval between esophageal balloon dilation, extending the symptom-free period without major complications such as perforation and temporarily improved the oral intake. We suspected that the reason of recurrence might be concerned with severe and tight scar formation of the esophageal anastomotic stricture. So our question is what type of benign esophageal stricture could be relieved by the use of the BD stent? Our experience suggests the problems of using BD stent were post-stenting symptoms and another stricture formation at the proximal or distal end of each stent. We especially think that when we use a BD stent for a young child, pain control is one of the most important things. Ladies and gentlemen, this is our conclusion. We believe that the BD stent may be preferable for growing children. However, BD stents should be further evaluated in design. particularly in regard to the proper size and the shape of young children. Thank you.